In this presentation, I'll be discussing respiratory syncytial virus. RSV infections begin in the upper respiratory tract and progress to a lower respiratory infection. Hospitalizations due to RSV occur between November and March and is the leading cause of lower respiratory tract infection in infants, the elderly, and those who are immunocompromised. Pre-hospital treatment is aimed at supportive care and management of symptoms. RSV spreads from person to person via direct contact with large droplets that travel up to 3 feet or 1 meter, and indirect contact with contaminated surfaces. RSV will survive on hands for up to 1 hour, but can survive on other surfaces such as toys or EMS equipment for up to 30 hours. The incubation period of RSV is 2 to 8 days. Populations at highest risk are children who are 2 years old or younger, anyone with a compromised immune system, and adults over the age of 65. Risk of infection increases in children in daycare, newborns who are born during the late fall or winter months, males, those who have siblings who attend preschool, children of smokers, members of large households, and residents of nursing homes. RSV primarily infects the apical surface of epithelial cells within the airway, causing inflammation and edema. Desquamation of epithelial cells and the collection of mucus and other material cause further obstruction, while macrophages collect within the alveoli to cause hypoxemia and hypoxia. RSV infection begins in the upper airway and presents with runny nose, nasal congestion, sneezing, cough, and fever. Initial signs and symptoms of RSV may cause it to be mistaken for a common cold. An important distinction between RSV and the common cold is the presence of wheezing with an RSV infection. Progression to a lower airway infection will manifest as bronchiolitis and pneumonia and presents with mild to moderate retractions, tachypnea, diffuse wheezing, diffuse crackles, mild hypoxia, chest pain, and nasal flaring. Immediate transport is indicated if the patient presents with lethargy, severe retractions, diminished breath sounds, or severe hypoxia less than or equal to 90% oxygen saturation. Many vaccines are under development, but there is no cure for RSV. Therefore, treatment is aimed at supportive care and management of symptoms. Place the patient in a position of comfort and continuously monitor the airway and breathing. Provide supplemental oxygen as needed. CPAP should be used in cases of severe respiratory distress. Artificial ventilation and intubation is indicated if the respirations are inadequate for the patient's age. Studies have indicated that corticosteroids are not effective in treating RSV, and racemic epinephrine may be harmful to infants. To prevent the spread of RSV, gloves and a mask should be worn whenever treating a patient with RSV. Hands should be washed or sanitized using alcohol hand sanitizer. Standard post-transport sanitation of the ambulance and EMS equipment should be performed.